So I realize actually quite a number of the points I was going to make in this workshop I've already made in the questions that people have asked and also my presentation. So I'll flip through some things quite quickly, but then spend a little bit more time on the things that we haven't covered, if that's all right. And so I'm really going to be talking about the potential benefits of regular outcome and process measurement. So not just the outcomes, but also measuring on a session-by-session basis the processes that you're trying to change in psychotherapy. So my plan of the talk is to say what we need to do to get complete data, why there are real benefits for getting complete data from patients. By complete, I mean data at the beginning and end of treatments at least, so that we know whether people have improved or how much they've improved, and what you need to do to get that, because it's not easy. And then talk a little bit about the advantages of getting some measures that really very precisely target the particular clinical problems that you're trying to treat. So not, say, just to generalize the GAD as a measure of anxiety, but more precise measures. And then I'm going to talk a little bit about the case for why it's useful to also measure the psychological processes that we're trying to change in whatever model of psychotherapy that we're using. And why that really does change outcomes a lot. So firstly, why it's important to get data. Well, I'm going to be quick on this because I mentioned this in the talk. I think the problem is that if we have missing data, it tends to be the people who've done less well that are missing. And so we don't really get an accurate idea of how we're doing as an individual clinician or as a service if we have missing data. And knowing what things are going well, but also what things aren't going well, is something that we all want, because this is what we got into the profession to do, to try and help people, but also understand the people that we're not helping and be able to think about what we can do with them. So that's why I think having the aim of getting data from everyone is really a critical one, because you're just in a much better place as a professional, because you know really what's happening. Of course, it's also the case that psychological treatments are much more difficult to deliver than medication. And of course, we have ways of trying to get around that. We try and ensure that we all get as good a training as we can, and hopefully many of us have the opportunity to get regular supervision, because there are lots of studies that showing however senior you are, if you don't get regular supervision, your outcomes tend to deviate a bit. But the experience of IAPT is that is simply not enough. Here we have a vast national initiative which has standardized training and requires every therapist to have an hour and a half of supervision every week. It's part of what happens if you're in an IAPT service. So, we sort of got that right, but that didn't give us the outcomes we wanted. At the start, you see, we were still a long way below where we wanted to be, and it took us quite some time to get there. But if we hadn't collected outcome data on everyone, we would never have got to our 50% target. And the only good thing I could say about it is we would have been ignorant of the fact that we hadn't. But given the scale of the IAPT program, I think I mentioned this morning, in terms of the public, that would mean that 100,000 people every year who we could get to recover wouldn't recover. And that's not what we want as professionals, is it? So that's why getting the data is really critical, because we can learn how to improve things from it. How do you get it? And I think this has summarized some points. Again, some of them have come up in discussion. First, I think it's really important not to spend too much of your time worrying about whether you've got the perfect measure. Decide on some basic things that you would want to measure in everyone and collect that. You can augment it with other things, but having a sort of minimum data set is good. And what will be the key characteristics of measures that you're likely to find you can get data from most people? Well, the first thing is they have to be brief. If you're getting someone to do it every session, and we find we don't get complete data unless you do it every session, so that's the answer to getting consistent data. But then it has to be something short. It has to be valid, so it has to discriminate between people with the problem you're treating and other people. So if it's a measure of PTSD, you have to score higher if you've got PTSD than if you've got OCD. It's got to be tracking the problem that you've got. And it needs to be sensitive to change. There are lots of valid measures which don't change very much with repeated measurement. They're very insensitive to that. They've got the wrong time frame. It's over the last month, say, whereas you're seeing people every week, so it has to be the right time frame. So think about all of those, and then give it every session, because if people finish therapy earlier than you anticipate, and that often happens, then if you aren't giving it every session, you won't have a final score. But you don't want to waste your valuable therapy time on measures. So what we would do, if we're using pen and pencil measures, we would give them the pack of measures to the patient at the end of a session and ask them to fill them in over breakfast or in the waiting room or on the bus to the session, but not spending any clinical time on it. But once, of course, they have filled them in, always make sure you pick it up from the patient straight away and always look at it. Because if you're not showing great interest in it, of course, they'll stop using them. And then do think about, can you have an IT system which will help you for all the reasons that we've talked about? Because it's very difficult otherwise. You don't have the time to do all this graphing and look at these things in detail unless it's done fairly automatically for you. And we're now using systems where people input them from the mobile phone. So if you can get your hospital or your clinic to invest in something like that, it really helps your life a lot. And patients really like it to do it that way. And I think you want to know your measures very well, and you want to choose the measures that you find most informative. And that means if you look at individual items, it will tell you something different if someone's scoring high on this pattern of items versus that pattern of items. I mentioned the case of PTSD where intrusive memories might be going down, but that might be because of a bad thing, avoiding more or avoiding less. You get that in most of the other measures as well. In the depression measures, like the PHQ-9, there's one which is totally critical, item 9, isn't it, which is on risk, and you'd always be looking at that. But then there are other measures which are telling you very much more, is there a sort of avoidance sort of thing going on there, which you could target with behavioral activation, or is there something else going on there? So always look at the measures on an item-by-item basis and track changes in the individual items. And I think it makes an awful lot of difference for the public buy-in if we're transparent with the public. And so our experience has been it is really good if a clinic puts on their website their outcome data. And the public really want to come and see you then. They can see actually people get better, because many people in the public think, well, mental health problems are bad, it'll be nice to get some support, but it's just going to take the edge off it a bit. I'm not really going to get better. And seeing that clinics are actually publishing data really changes public perceptions a lot. And I explained that, at least in our national thing, we try and construct these measures so that there isn't an incentive not to collect the data. But I think you all understand that bit of the maths, don't you? So I'd like to say a little bit about why it can be useful for some of your measures to be really very targeted on the problems that you're treating. So here's an example, social anxiety disorder, one of the conditions that we treat. This is from one of our randomized controlled trials. And so we have on the far corner here a measure of recovery, which is the standard IAPT one. It's have you dropped below the clinical threshold on the depression measure, which is a PHQ, but also on the general anxiety measure, which is the GAD. The trouble with just using that in social anxiety is that none of the items measure anything to do with social interactions, and they don't measure social avoidance. Whereas there is a measure which we recommend in our services called the SPIN, which does measure those things. And if you don't give that, you can see you can get very misled. So in this study, what I've plotted here is the recovery rates using the general measure of anxiety and the general measure of depression. And you can see in this trial where you are offered up to 14 sessions of therapy, by session 7 you're doing fabulously well on the general measure. 71% of people have already recovered. But you can see actually on the SPIN and the PHQ it's only 28%. And the reason for that is that what happens in therapy is early on, people get much less anxious in the situations they're already going into, but their life is still very restricted because there are lots of situations they're completely avoiding. But the GAD won't pick that up. And you can see that that's what's happening, because on the first column you have something called the WASAS, Work and Social Adjustment Scale, which is a measure of how much you're disabled in your life, family life and work by it. And you can see 71% recovery on the GAD and the PHQ, your life hasn't changed. The WASAS has only come down a little bit, but once you come down on the spin as well, you can see a big change. You've changed someone's life. So it's really very important to measure the particular thing that you want to change precisely, as well as having these general measures. I know there's a big debate in psychotherapy about this, but if you want to change someone's life, then you need the specific measure as well, and you need a measure of disability. How much is their life interfered with? It's not just symptoms that you want to measure. So then I'd like to finish off by talking about process measures. So all psychotherapists, whatever school they're from, have particular psychological processes that you're trying to target in therapy. And ideally, you want to be able to measure those on a regular basis as well. In our experience, we're cognitive therapists, so all of our work is on cognitive therapy for anxiety disorders. We find it immensely helpful to have measures of the constructs that we're trying to change every session. So we have a measure of common negative thoughts that people have in different conditions, whether it's PTSD, social anxiety, panic, and how much they believe them. And we look at that every week, and we adjust what we're focusing on in therapy on the basis of which are the thoughts that have the highest belief ratings that week. And we may start with a particular set of thoughts because they have the highest belief ratings. As we deal with them, some other thoughts now are the ones that are most pressing, and we shift the focus of therapy onto that. Similarly, there are certain types of safety behaviors, protective strategies that people use to manage their anxiety. We'll give regular measures of those, and we often find that if you look at it midway through therapy, people have improved a lot, but they're still using some of these safety strategies. But if you can measure them systematically, you can focus the second half of therapy on really just removing all of those safety strategies. But if you haven't got regular measures, you won't know that. And I think this is one of the main reasons why cognitive therapy social anxiety does so well in comparison to other treatments, because in most of the trials where it has done better than other treatments, we've had session-by-session process measures, and the therapists have been using those to guide the content of their sessions. There are a couple of international trials where that wasn't done. So there's a German trial by Falk Lauschenring of cognitive therapy versus psychodynamic therapy, and Falk prevented the therapist from using any process measures in cognitive therapy. So they weren't allowed to measure the negative thoughts, they weren't allowed to use safety behavior measures. And although cognitive therapy did better than the psychodynamic therapy, still, in this particular case, the difference, neither treatment did anywhere near as well as in those studies where you're measuring process all the time. So that's just a plea to add that into your armory. And that's really all I wanted to say, other than I mentioned there is a free therapist resources website that we have from our clinic. And if you're interested in process measures, particularly for cognitive therapy and social anxiety, panic, PTSD, you'll find them all on that website, along with lots of videos that you can watch if you'd like. Because we're sort of thinking now that therapist manuals, they're okay, but they're not great, because if you're presented with a patient coming into your next session and you want to know what to do with them, you're not going to read a whole chapter in a therapist manual. But we have 10-minute clips of some of the key interventions, and we find a lot of therapists will look at that before the patient comes in. So it augments the sort of manuals. And thank you very much.
Thank you very much, David. I'm going to kind of build on David's talk and take us in a bit of a different direction, if I can get my slides.
It's not a touch screen, I think it's probably we have to minimize it.
Okay. trying to shut it down. Let's try
Yeah.
to do that like that. Okay,
Yeah,
very
good.
good. All right, thank you. All right, so what I hope to do in a few minutes with you is to talk about evidence-based practice and practice-based evidence and distinguish between the two, to look at outcome monitoring in group therapy, and talk about challenges and opportunities in implementation of outcome monitoring. So first, a general word about psychotherapy effectiveness. And you'll see that David and I have similar and different interpretations of the literature. What we see is that a lot of reviews demonstrate the psychotherapy's robust effectiveness, highly sought after by patients. And a series of meta-analyses signal to us that there is generally no single gold standard of psychotherapy if we're looking in particular for complex patients, depression in particular. We can also recommend group therapy as effective and equivalent to one-to-one therapy with a moderate effect size, and it's more efficient with regard to therapist resources. And recently, group therapy has been recognized by the American Psychological Association as a distinct specialty, which we see has a big advance because it's going to, I think, really elevate rigor in training. We also know that access to mental health care is challenging, and people in North America are getting less and less access to psychotherapy and are being prescribed antidepressants at a much greater rate. 1 in 5 women in America is on an antidepressant, which is a stunning figure. So having made a point about fundamental equivalence of therapies and models, that's, I think, fairly good news. The not so good news is that there is no such equivalence with regard to therapists. There's enormous variability with regard to how therapists do with their patients. And this work emerges from a series of studies of looking at practice research networks. So it's helpful, I think, to think about being an evidence-based practitioner in addition to using evidence-based psychotherapies. And if we think about things in this context, then we move in addition to empirically supported therapies such as cognitive behavior therapy for social anxiety. We look at the role of practice guidelines, and we look at the role of practice-based evidence, which is my segue to outcome monitoring. And I see this as essential to remedy the quality gap, because I think one of the worst things we can do is provide poor quality psychotherapy. It demoralizes patients, it demoralizes therapists. And because our work is relationally based, what we do matters, and how we do it matters sometimes even more. That's the implementation gap that we have to remedy. And you heard an earlier question about common factors, and what the literature tells us is that therapist effects and common factors like the therapeutic alliance contribute 2.5 times as much variance to outcomes as does a particular model. And we need to be alert as to how we can use those elements that reside within us and reside within the psychotherapies across the board. We have to be mindful of culture, and we have to deliver what we do well. The American Psychological Association recently completed its 3rd task force looking at what is correlated with effective psychotherapists. And the findings echo the 2nd task force with some new emphases. Therapeutic alliance or group cohesion, if we're looking about group therapy, has a medium effect size, good correlation with outcome. Empathy, similarly, good, strong correlation with outcome. Empathy is tailored, it's specific, it embraces cultural dimensions, and it involves not only the receptive capacity to understand, but the expressive capacity to understand and communicate that. It adapts to and privileges patients with regard to their attachment style, and as I mentioned, the role of culture, reactants, other patient variables. The third important domain that is associated with better clinical outcomes is client-centered outcome tracking, and that's what I'm going to focus on for the rest of my few minutes. Why is this important? I think David has made already a strong case about how much outcomes improved when data was tracked. Why is this important? Because we underestimate deterioration effects. And there's a study in individual therapy and a study in group therapy that when therapists are told you have patients in your care who are failing, therapists fail to recognize this clinically. It's quite surprising, but the findings are robust. Some of it, I think, is our own lack of self-awareness. 90% of therapists rate themselves as being the top 25% performers, and that their patients get better at a much higher proportion than they actually do. So routine outcome monitoring is a way for us to offset our therapist positive bias and our overestimation of our effectiveness and catch deterioration or patients who are off track earlier, so we have an opportunity to remediate the difficulties. And a series of studies have shown that patients at risk of deteriorating who are being monitored are much less likely to deteriorate. And if you add not only outcome monitoring, and I'll talk in a minute about some of the prevalent models, but you add clinical support tips to therapists, you again dramatically increase your effectiveness. And we see positive outcome on clinical outcomes, reduced dropouts, and reduced treatment failures. And SAMHSA, the American Substance and Addiction and Mental Health Agency, looks at evidence-based practice as including routine outcome monitoring. So if you want to be an evidence-based psychotherapist, do what you do, but do it in the best way possible. And the best way for you to know that you're doing it in the best way possible is don't assume you're doing a good job. Get data that shows that. So in essence, everyone in this room can be a local clinical scientist using the equivalent of GPS in your car to augment your clinical judgment. A couple of the more prominent systems that are used in North America are the OQ45, the Outcome Questionnaire, or the Partners for Change Outcome Monitoring System. And generally what these systems have in common is that they measure outcome based upon individual distress, well-being, interpersonal relationships, and social function. And they also capture a process measure, as David referred to, that evaluates what is the quality of the relationship, what is the quality of the alliance, and gives you data that tells you you're on track. You get a green message, yellow that says this patient is not progressing the way he should, or a red message that says this patient is off track and headed for trouble unless you do something differently. If you're working in the area of group therapy, that process measure could be effectively used as the group questionnaire, which samples the patient's experience of the quality of the bond, the presence of negative factors in the relationship, and the quality of the work. Group, as we know, is much more complicated than individual therapy because you have so many different layers of interaction, but the data that's coming out from recent studies shows that using a group cohesion, group questionnaire measure improves your ability to assess what's happening in your clinical care. Feedback can come to you as a therapist, it can come to you and your patient, or it can be aggregated at a system level. The more you use e-platforms, the easier and quicker it is because we want to be able to get this data in a quick and timely fashion. And you can even use the reports as part of your clinical record keeping. What the routine outcome monitoring also shows us is that For treatments that are progressing generally well, adding routine outcome monitoring probably doesn't give you a big return on your investment. But for the 20 or 30% of unrecognized treatments that are going poorly, it has a dramatic impact, improving outcomes from 1 in 5 to better than 1 in 2, and reducing deterioration rates from 20% to 5%. Patients can be readily engaged in using these kinds of measurements. It's often the providers who are reluctant to utilize this rather than the patients. And evidence shows we can improve quality of care and reach more collaborative decisions about duration of treatment. What the literature also shows us, and what clinical experience shows us, is that providers are often resistant. This was a question that came up at the panel. I think people don't like the scrutiny. They don't like the intrusion. And as Bruce Walpole has noted, if you have to pay for your patient's measurement, it's the equivalent of asking a general practitioner to pay for the blood work that patients in his or her clinic see. So we need a kind of macro level response to make this more widely adopted. And some studies have shown that when this is introduced into an organization, and I think David made reference to this earlier this morning, some people are going to be very unhappy, and if the organizational culture is critical and shaming, people will use the data as a reason to punish therapists rather than to elevate their performance and effectiveness. And of course, the most important thing is that you get the data, you use the data. And there are studies that show for some people, even when the data is easily accessible electronically, it's not embraced and utilized psychotherapeutically. This is what the outcome monitoring looks like if you are working in a group. You'll see, obviously a made-up name, you'll see feedback about the positive bond, positive work, negative relationship. You can get it on each individual patient. You can get a group questionnaire outcome on each individual patient or on the group as a whole. And you can see a series of outcome questionnaire alerts that shows you what the initial score was and what the most recent score was. And you get a red alert for somebody who's deteriorating, a yellow alert, green alert, as I mentioned before. I want to share quickly about how this kind of routine outcome monitoring can be transformative in a system. I was a consultant to Mercy Behavioral Health Care in the States, and they demonstrated really a transformational approach to providing care in 23 hospitals, providing care to 25,000 patients in the US Midwest by using group therapy and monitoring outcome. And this was a Mercy Hospital in Chicago, like the Mercy Hospital you see on TV. It was a place where security guards would only walk in pairs. It was that level of disturbance. But across their system, they found that they were able to move beyond meds and beds to meaningful, effective, and memorializing care by training their social workers how to deliver group therapy, monitoring that, and utilizing outcome data to improve quality of care across the system. We describe a kind of friendly competition that developed across different settings. Transformative with regard to patient satisfaction, transformative with regard to staff morale. They trained 60 people in their network to be certified as group psychotherapists, much in the same way that IAPT trains people. And for those who work in these settings, a significant reduction in aggression and critical incidents from 50 down to 54 from 67. And the continuous quality improvement opportunities contributed to early problem spotting and promoted reflection and reduced the risk of therapist drift, which happens in any kind of ongoing therapy. So that's the last thing that I wanted to say, and welcome David back up on the stage, and we'll have an opportunity for questions and comments, and thank you for your attention so far. I think, David, you left your watch here? All right, so we're open for comments, questions. Yes. And I'm also going to encourage, this is a good opportunity in a workshop setting. If you have a question, even if you feel kind of tentative about it, don't hesitate. We want to encourage as much participation as possible. Okay, we'll share this up here. Thanks.
Thank you. My question is about Dr. Clark's reference to both having outcome measure and process measure. Actually, my understanding of outcome measure is checking how the client is doing based on some criteria, and also it not only shows if the client is improving or deteriorating, it also reflects how the practitioners are doing. But the presence of process measure, like a routine process or routine checkoff during each session, when we do this, aren't we running the risk of kind of compromising the genuineness and spontaneity of the treatment? Because it looks to me like a list of checkoff for, I'm talking about process measure. Going through a list of checkups to see if I, as a psychotherapist or psychologist, have done things regarding my treatment plan or even the treatment mode I'm actually employing. And then it looks like a report to my supervisor than just having a feedback of what's going on during the actually therapy. Because already the outcome measure gives us that feedback. Or maybe my understanding of actually process measure is different than what you meant. But
Yeah.
that's my understanding.
Yes,
and difference between outcome measure and process measure.
Yeah, so I think I didn't explain what I meant by process measure clearly enough, because the process measures we have are nothing really to do with the therapist's behavior. They are measures to do with psychological constructs that you're trying to change in therapy. So if you're treating someone with social anxiety, there are lots of different fears that people have. They might fear that people think they're stupid. They might fear that people notice they're blushing and think they're weird because of that. They might fear that people think they're inadequate in some way. And so we track those beliefs as we go through therapy. And what we find is that you may focus your early therapy on a small number of beliefs and change them quite a lot. But if you are giving regular measures covering a whole range of beliefs, you can spot that you've got some other beliefs that you haven't really touched in therapy. They haven't been mentioned much by the patient, but they are still strongly believed, and so we focus on those. And the reason we do this is because of a painful experience in our first ever randomized controlled trial. So it was a trial of treatment of panic disorder. Overall, the results were good, but when we finish a clinical trial, we always do what we call a post-mortem. We take the whole team, we lock ourselves away in a room for 3 or 4 days, and we just look at those patients who didn't improve as much as we wanted them to, and we try and learn from them. We look at the tapes, we look at our notes and things. And what we found is that we were giving one of these measures, a wide range of beliefs, at the beginning and end of treatment for research purposes, but the therapist hadn't looked at it. And we had a couple of patients who really, we got down, it took us right down to the wire to get them panic-free, and 2 of them didn't get panic-free. And then when we looked at this measure, we found that at the beginning of therapy, they had a couple of beliefs, one of which is I'm dying, which never came up in the therapy sessions, and so it was never challenged. But if we'd been looking at the measure, we'd never have got into that problem. So that's why we measure, because it's cognitive therapy, a whole range of beliefs, and make sure we cover the whole cognitive territory. The other thing in social anxiety that you're very interested in is people's focus of attention. We know that when people are very anxious, they focus their attention very much on themselves. We want to make them more externally focused so they can pick up how other people are responding to them. And if we have a measure each week of the focus of your attention, we can see whether that's changing or not. If it's changing nicely with what we're doing in therapy, then we don't bother about it. We just let it carry on. But we find some patients in whom they're still staying very self-focused, even if their beliefs are changing a bit. And we know for those we have to work on shifting their focus of attention. So it's those sort of processes we're involved in. But I think Molyn also gave a very good case for tracking the therapeutic alliance, which is another process which is central to therapies. And you could see quite clearly that tracking that was helpful, because you could see from that chart with Peter Pan, the therapeutic alliance wasn't all that good. And the therapists may not have been entirely aware of that because they had a positive bias, but the tracking would help them. But I'll let Molyn finish that.
I appreciate your question, and we want to make room also for other people's questions. Because your question speaks to one of the common resistances therapists have, that getting that kind of process data about the quality of a relationship may feel like it's going to distort treatment, or it becomes self-serving, or what else is the patient going to say except, yeah, you're great. But the experience in the field is that people are often more honest on these kinds of measurements than they are face-to-face, although I would strongly encourage always trying to do this face-to-face as well. As you heard earlier, it's the patient's experience of the alliance that is most highly correlated with outcome. So we want that experience. Thank you. Peggy.
Hi. I'm not sure if this is the right venue to ask the question, so if you'd prefer that we maybe take it up after, that would be okay too. But I'm involved right now in the rollout of health quality standards for anxiety disorders and OCD in Ontario. And it's a really great opportunity because with the launch of these standards, we have the opportunity to develop aspirational standards. But we don't have a mandate to enforce adherence or change. And so I'm really curious about any advice you can give. We are planning to embed in the standards statements about the use of routine outcome monitoring, because I firmly believe that the evidence is there, as you've both shown us so convincingly, that this is the way we need to go. And yet we know it's really difficult for clinicians to embrace this kind of a shift in their practice. I think in IAPT you had the big advantage of a leadership that was invested in it and could mandate it. And we won't have that. So I'm wondering if either of you have any thoughts about one or two best ways to kind of, if we had the opportunity to make a couple of requests for support around rolling out these standards and making sure this happens, if you have any thoughts about one or two best ways we could support this happening.
Well, I think, always the first step must be to win the agreement of your workforce, mustn't it? And so, you won't be surprised for me to say as a cognitive therapist, you want to get into the head of the people that are not using the measures, try and find out what the block is for them, and then, work with them on that. In IAPT, we have some little role plays we sometimes do. So you might have some therapists who are not that keen to measure depression every week session or something. We might say to them, well, let's take someone who goes to their doctor, they've been under a lot of strain, a lot of stress, and the doctor takes their blood pressure and finds it's really pretty high, 160 over 110 or something, and says, well, you've been under a lot of stress, it's probably just that, but come back in a week and we'll see, what it's like, and then it's still way up there. And then the doctor says, well, maybe that's not a transient thing, maybe we better do some 24-hour monitoring, and it comes back and it's still high. So the doctor then says, well, actually, there's a very good chance you'll be dead within 10 years at this level of blood pressure unless we deal with it. So we've got to do something. We could work on your diet, but I think we need some medication as well. The good news is there are lots of medications that work, but we have to try and find the right one. But I don't want to overstress you, so I won't take your blood pressure each time, just trust me. And, most patients look at you and say, you're totally mad. I say, okay, well, let's take it into depression. So you've got someone who comes along, they come up high on the PHQ, and it's just this one episode, and the clinician is seeing them and says, well, it sounds like you had a big disappointment at work and things like that, but hopefully things will be a lot better next week. But let's just meet up in any case, and it's still up there. And you're also coming out quite high on item 9. You're feeling maybe life isn't worth living and things like that. You say, well, I think we need to get into some treatment here. This is quite important because actually, there's a chance you will be dead in the next 10 years from your own hand. But I don't want to stress you by measuring things too much. I'll just try out different things, and hopefully we'll get to the right place. It's no different, is it?
The reason that I made a comment about the Mercy Behavioral Health is anticipation of that kind of resistance. And what you need is organizational buy-in, an organizational culture that is interested in the professional development of the people who work in the program. No one likes to do work that isn't effective. It's demoralizing. And I think you can begin to make the case for this is going to improve the quality of your patient care and the quality of your professional life. And we're going to use the data in a way to make you more effective, not in a way to beat you up. But in the wrong hands, it can be misused. But in the right hands, I think it elevates care and it elevates the quality of life for the providers.
That's another really helpful answer, isn't it? And we mentioned IT systems as well. On Monday, we're having a conference call. All of us are involved in planning NHS provision in mental health. And one of the things we're going to debate is whether we are going to adjust the funding that we give to different services, dependent not on the outcomes they get, but on whether they collect outcome data. And I think it is very likely that because we're expanding funding in mental health, there's a new commitment to that, that we will adjust the amount of funding that we give to different areas depending on whether they are able to consistently collect the data without going the extra step and saying, and you need this particular outcome, but just say, you have to get the data. So that's a thing worth thinking about.
Thank you for all of the different information you presented today. And I'm interested in outcome measures too, but I realize this conference is focused on CBT. I'm going to talk about a psychodynamic dimension, which is transference, because I'm particularly interested in certain people that I've seen in my own patient population over the years, which is a complicated collection of people with anxiety disorders, but also characterological issues, one of which is the good woman pleasing patient, and how your outcome measures can measure for those kinds of things. Because I've seen many people over the years that I could probably write a paper on, quote, failed CBT, because what has happened is the person has played along with the expectations and the treatment and has said thank you very much and has gone on for 6 months and then tripped into quite a profound depression because some of the interpersonal dynamics aren't being addressed in the CBT model. And I'm just wondering what, if any, things you're looking at that in terms of the measurement and how you control for that when you're looking at outcomes.
Yeah. So the first thing to say is that there are failed cases of every therapy. That's just a fact. I think with outcome monitoring, you need to look as broadly as possible. So it's very good to have some minimum data set that you agree on and everyone tries to collect it, but you mustn't get obsessed with just looking at that. You need to look at the patient in the round. Our view is that you also need to make sure you measure things that the patient says they want measuring. So we often as clinicians measure clinical symptoms. Most often patients talk about disability, how it's interfering with their life, what they can't do. And so it's important to have both of those. But the other thing, which is very relevant to your point, of course, is to track people over a long period of time. Because the goal of psychotherapy isn't simply to get someone better at a particular time, it's to keep them well in the long term, isn't it? That's what we're all in the business for. So it's not just the measures you select and making them broad enough, but it's also tracking people over the long term. And of course, if someone's had some therapy and they and things go badly wrong in the future, you want to know that, and you want to know it as quickly as possible.
But I guess that what I was, maybe I wasn't as clear about was how you're looking at outcome measures where the patient, because they want to make sure you feel good as a good therapist, is saying that things are going a lot better than they really are. I mean, I personally have been tripped up by that myself.
Yes.
And how you can control for that, if
Well,
at all.
Yeah, so in clinical trials, of course, we have a whole methodology for controlling for that. We have independent assessors, and you don't get a trial published unless you have independent assessors. In anxiety disorders, we also have behavior tests that we use a lot. So the video I showed of the person with height phobia is an example of that, isn't it? You can see, can he really do things or not? Much less dependent on self-report. In PTSD, you know, we try and get people back to the site of the trauma and see how they react emotionally. And so certainly in anxiety, I think it's pretty important to get people into the real situations that provoke the anxiety and see if they've emotionally changed, not just a self-report to you as a therapist in the clinic. Depression's a bit more tricky, isn't it? Because we don't have such a broad-based way of looking at that. And so I think it can be an issue.
Is there a question over here?
So you sort of addressed my question about kind of like the social desirability bias, but I have another question regarding, you talked about, you know, collecting outcome measurements, which again, as everyone has heard, is very, very important. But you talked about collecting them every session, and my question to you is more so, especially because it's based on self-report, what is the susceptibility to testing effects, that repeated testing over time, especially clients who are coming in, you know, once a week, multiple times a week? Can you elaborate on that?
Well, so I mean, most of the measures that we use have a time frame of a week, so it's not appropriate to give them multiple times in a week. So if someone's coming in more than once, you'd still only give it once a week, is the way we do it. I think for a lot of these measures, there is likely to be some sort of repeated measurement trend, isn't there? But there are quite a lot of trials, of course, that are repeatedly giving these things in wait lists as well, and you don't see the same sort of big drops. So I wouldn't rule them out, but for most of the measures, it's known that it's a quite modest effect.
Yeah, I think he was next, and then Abby, or then Gilly, yes. Hopefully we'll have enough time.
I'm just curious if you have any advice with respect to bringing outcome measurements to administrators to have that implemented in systems, because this is something that I'm doing in my own practice, and we're involving some of the outcome measurements that we already take, but the individual sessions and the session-by-session rating isn't happening. So how to get buy-in from, I guess, administrators?
Well, I suppose with IAPT, you know, we sold the model and we got the government investment for it, and you know that is a key bit of the model. And the administrators didn't have a difficulty with that. They realized quite early on that it's better to have for them to see the data than not. So that worked out well, I think. If you're working as an individual therapist, it's a different issue, I guess. Is that your situation?
I'm part of a clinic in a hospital.
Yes.
So there are some clinicians that use it. We did the training, but system-wide it hasn't been implemented. So the aggregating and the IT integration hasn't happened.
Yeah, so that makes it much more difficult if you don't have an IT system to support you, doesn't it? But I think also, you know, if you're working in a situation where, you know, you've got a supportive group of therapists there, then we've had some wonderful experiences with people, you know, in their mutual sort of supervision, sharing their outcome data. So the thing that really got me hooked on this was the last of the very big bombs from the IRA. So in August 1998, the IRA planted a car bomb in a particular city in Northern Ireland, Omagh. A message came and it actually identified the location of the bomb wrongly, so the police moved everyone to stand around the bomb, and then it blew up. 31 people were killed, 531 died. were injured. And there was no real expertise in treating PTSD, so we were asked to come and train the local clinicians in treating PTSD. And we had clinicians from lots of different orientations really wanting to help. But most of them hadn't got much familiarity with trauma-focused CBT. But we did group supervision, and every time we did the supervision, we put up the sort of outcome measures of each case at the start of treatment and the last time they were seen on the board. And it was just the most wonderfully informative thing, because we had an enormous amount of group learning. We saw there are some things that really worked well for these particular people, some of the beliefs they had about other people in the community who may or may not have been involved in the bombing, for example, and addressing those really pulled down the PTSD well. Other things didn't. But this was a sort of group learning that we got, because we all saw everyone's cases and we heard what each person was doing. And it actually produced, in a very short period of time, a real interest in learning this particular treatment. That's what we were training. So people had come from very different therapeutic backgrounds, but they moved in a way towards acquiring these skills very rapidly, because they saw the outcome data on all the cases. And some of I'm very close friends with many of them still, and many of them say about it, they never really would have learnt the power of this treatment approach if they hadn't gone through that exercise, because they all knew they were doing things that were useful for patients. But what they wouldn't have known is how the other therapist treated someone who seemed as tricky, but they'd done something slightly different and they'd really improved a lot. So it really is a journey of wonderful discovery in a group, but you can't get it unless you've got the data.
Is there anything, do you have anything published about that experience? No, okay. Because it's a good story that illustrates it well.
Yeah, we use session. There is one thing published. So the reason we have session-by-session outcome monitoring in IAPT is because of that bomb. Okay. So what happened is that there was a concern that one of the nurses in the local psychiatric hospital may have been involved as a bomber. And so absolutely no one was going to go to the psychiatric hospital for treatment of their PTSD. So there had to be a drop-in center created in the town with actually rather minimal records on people as well. And so they would just come in and we'd give them therapy when they came in, and we don't know whether they'd come back next time. But we wanted to see whether we're doing anything useful. So that's why we decided on session-by-session monitoring. And we got data on everyone from that, and we presented it to a government minister, and he gave money to found a trauma treatment center for the next 10 years that treated other victims of terrorism. So that's what taught me that getting data generates money, and getting it every session is the way to get it complete. But no, I haven't talked about that other bit of the story.
Yeah, it's helpful.
Yeah.
Thank you.
I'd recommend an article by Whittingham, which I've cited in the journal Psychotherapy, published in 2018, that talks about the transformation at Mercy Behavioral Health. And they did many of the things that David has referenced. They provided feedback, they videotaped group sessions, they provided supervision on the group sessions, then they had subsequent data, they saw the improvement in outcome, and they just built on itself in that kind of way. Bringing people together to learn together and to support one another is integral to this. You can't do this very well just in isolation. I think we have time for one or two more questions. Nope. You got to break up now? Okay.